Hi, I'm Christina and welcome to another one of my cancer translation videos. This might be the first video you're watching of mine, and so let me just give you a little background. I do cancer clinical research, and I've been doing clinical research for about 16 years now. And I know that the language that a lot of us in clinical care use when we talk to patients is not always the easiest to understand. We forget to back off of our medical jargon sometimes and speak more plainly. And so I wanted to make a video, or actually several videos, that explain things in a little bit more down-to-earth language, in just ways that are easier for people to understand. So that's what I'm doing with these videos, and just kind of trying to put things into layman's terms, if you will. So this video is a big picture overview of cancer treatment. I'll get into more detail about chemotherapy in later videos because that takes a lot more time. But I'm going to just talk about cancer treatments big picture in this one. So what I've got already written up here is cancer treatment. I've got surgery, radiation, and chemotherapy listed because most of the time if you get cancer, you're gonna get 1, 2, or 3, maybe all of these together, or some combination of them. And so I was gonna just walk through these, talk a little bit about each and why you might get one or both or all of any of them, depending on what kind of cancer you have. Now, to back up here, just a little review from my other videos. Of course, the definition of cancer is cells that are dividing rapidly and out of control. And also a disclaimer or a reminder of sorts is that cancer is not one disease. Different kinds of cancer are really different diseases. Different kinds of cancer respond differently to different treatments. So that's why not everybody is going to get the same treatment. Somebody with breast cancer is not going to get the same treatment as somebody with colon cancer is going to get. These cancer cells are living things. They are living cells. They started out as normal cells inside of you. And I apologize. I realize that most of you watching this don't have cancer, but it's just habit for me to speak as though you are a patient. So forgive me as I keep saying you. But cancer cells start out as normal cells inside you, and they obtain mutations, or mutations that are already there get turned on, and then they lose the stop signal that's supposed to tell them to stop reproducing, and they don't know to stop, and they keep going and going and going and reproducing and copying themselves over and over and over again. So, but the thing about that is they're your cells, they're human cells, and they're alive, and they respond to things. And depending on the kind of cell they started off as, they have different qualities, and they're going to respond differently to things that attack them. Okay, so I stopped and did a little erasing so I could draw some. So let's talk about surgery first, because that's usually the easiest to understand, right? You just chop it out. It's pretty much the idea, right? Sort of. So let's talk about a few of the main ideas behind surgery for cancer. So generally speaking, you're going to have a tumor. Now, if you are lucky enough to get diagnosed with early cancer and your cancer's just in that one spot and hasn't gone anywhere, it may be that you can just have surgery, remove that tumor, and you're done. And that's ideal. But whatever the case may be, if they're going to go in and remove a tumor, they're going to go in and they're going to cut around this tumor, because you don't want to cut into tumor. Tumor doesn't like it when you cut into it. But if you cut into tumor when you're taking it out, you can spill tumor cells all into that area where you're taking the tumor out, and you can leave some behind. And that's not a good idea. We don't want to do that because we just don't want to leave any behind if we can help it. We want to take as much as we can get. The best way to do that is to take out an area around it that we know is normal. So what we do is usually get, in most cases, about a 1 centimeter, what we call margin of normal tissue around that tumor, so that we are pretty sure that we are well clear of the edges of that tumor, and that whole thing should come out. Now, not only do we, in most cases, cut out the tumor, but we also cut out these wonderful things that everybody has heard of, some lymph nodes that are in the area. Now, cancer cells want to take over your whole body. If they have their way, they're going to take over the whole place. And to do that, they need to travel, right? And they will travel by your bloodstream. They do that sometimes, but their preferred method of travel is through the lymphatic system. Now, not everybody knows this, but you have blood vessels and you also have lymphatic vessels. Lymphatic vessels are little vessels, like blood vessels, but they connect lymph nodes to each other. So the cancer cells use these lymph nodes like little bus stations that they would get on. They kind of get on the bus at the bus station and travel through these lymphatic vessels, which are kind of like their highways. And so we don't want them to travel anywhere. So what we want to know first is, how were they getting ready to travel? Were they already traveling? Where were they in that process? So we take out these lymph nodes, some of these lymph nodes that were in the area around the tumor, and we also send those down to the pathology suite to the pathologist, and the pathologist is going to look inside those lymph nodes too and see if there's our cancer cells inside those lymph nodes. And depending on how many lymph nodes have cancer in them, we may add more aggressive treatment or not so much aggressive treatment after your surgery. And this is part of the staging system, and I'm going to do a whole separate video on staging. But staging cancer, it's kind of like, it's almost like a numerical thing. You add up points and you come to a stage for that kind of cancer. Part of it is how many nodes are positive in a certain area. It's different for each different disease site. What makes something a stage 2 lung cancer is different than what would make it a stage 2 throat cancer. But basically, knowing how many nodes are positive in the area, that kind of thing, contributes to giving you a total overall stage. So, and that's what we use to help decide how much treatment you need. So, but basically, in general, besides just looking at treatment planning, that's telling us, okay, if there's some cancer cells in those lymph nodes, then this cancer was already about to escape. It was about to get on the road and start traveling, which is a little concerning because cancer is the hardest to treat when it gets to another part of your body. Once cancer has spread to another part of your body, that is when it is very, very hard to treat. And that is when you're really going to struggle there. So we really want to catch it and get as much treatment in as we can before it gets to another part of your body. So what we want to see is that there's no cancer in any of those nodes, or maybe only one or two. That's what we want to see. And so that's what we'll find out with that surgery. So the surgery, not only is it good because it takes out your main tumor, but it gives us some information about how far that cancer was in escaping the area and moving on to another part of your body to do its evil takeover. It's got a plot. It's going to take over the world, which to it is your body. So we want to know how far along it was in its evil takeover plans. So that gives us information. So surgery is often, not just, treatment, but it's also, information gathering. So anyway, but here's the thing, not everybody gets surgery, right? We all know that. So why might you not get surgery? Well, obviously some people have some conditions that make it so that surgery is something that's too risky for them. That kind of makes sense. But it also matters where your cancer is. Some places are just places that are harder to get to and places that we don't like to operate on because, well, let me give you an example. Okay, let's take lung cancer. If you have a tumor in your lung, that tumor is sitting right smack in the middle of a vital organ that we would like to keep very much, wouldn't we? So, like I said here, if you're going to cut out a tumor, you're also going to cut out an area around it of normal tissue. Well, if you're cutting out an area of normal tissue in your lung, that's different than cutting out a normal, an area of normal tissue in your arm where it might just be fat cells or something. Cutting out an area of normal tissue in the lung is taking extra lung tissue that you really want to keep. So we don't like going in there and taking out lung tumor and extra normal lung tissue. That's not great. We want to keep as much lung as we can. So that's not ideal at all. Plus, lung is hard to get to. It's in a cage, right? It's wrapped up in your rib cage. It's snuggled in there with your heart and your esophagus and all kinds of other important things. So, it's really not easy to get to either. So in the case of lung cancer, we really don't go for surgery first in most cases. We go for chemo, maybe with some radiation, but chemotherapies have been really developed really well in cancer because of the fact that we just tend to lean away from surgery in the beginning. So they have a lot of different chemotherapies for lung cancer for that very reason. Now, think about breast though. Breast is obviously easier to get to. So a lot of times you will consider surgery as an upfront option for treatment more often in breast, just simply because it's easier to get to. And things like that are going to come into consideration for what you're thinking of as far as whether you're going to get surgery up front or not. How big is that tumor? If it's really, really big and that surgery would be tough because of how big that tumor is, maybe we might want to try to shrink it first. Maybe do some chemo and radiation first and shrink it so that when we do the surgery, it's a smaller surgery. That's another consideration. So that may be a case where you get surgery, but you get it later and not first. That's one thing to consider about getting surgery. And, so there are all kinds of things to consider here about the timing of when you might get surgery, whether you would get it at all. And then another thing is critical structures. And what do I mean by critical structures? Those are very important things that you want to be really careful not to mess up in the body. Here's an example. You have these two big fat arteries right here that send blood up to your brain. Of course, the brain is very important. We have to have blood going to the brain. If you don't have blood going to your brain, you die, right? So we don't want to do anything that's going to mess up these two big fat suckers that are sending blood up to your brain. These are your carotid arteries. You may have heard of them. So if you have a gumball-sized tumor that's sitting here on one of these carotid arteries, it is not going to make a surgeon real excited to tell him to go in there and cut a tumor off of the carotid artery. That's really risky. There's a chance that you could accidentally cut into that carotid. That would be bad. That's not a risk that surgeons like to take. Now, if you have that same gumball-sized tumor and it's a little bit further away, sure, they'll go in there and take that out. So, within your body, if that tumor is close to a critical structure, that might not be such a great idea. It may be too risky. They may want to do some chemotherapy to try to shrink that tumor away from that critical structure. So, where it is in relation to things that could be just cause or, be very risky to get near, that's kind of a consideration too. So all kinds of things involved in that kind of consideration. Now, let's do radiation next. So radiation, of course, is another one that everybody's heard of. And so what radiation is you're taking very focused beams of energy and you're zapping that tumor. Now, radiation oncologists, which are the kind of doctors that do this, hate it when you say that you're zapping their tumor. So if any of them are watching this, they're not liking me very much right now. But as far as layman's terms go, that's probably the best way to say it. You're zapping that tumor with some very, very focused energy. And you're kind of frying it. So again, definitely not the correct term. Definitely not the scientific term. But that's what's happening. And you've got this huge, super complex machine that is focusing these beams on this tumor. And they have these super, super smart people called dosimetrists that are using these super complex physics formulas to map out your tumor and calculate exactly where those beams are going to get them to shoot in exactly the right place. And so we're shooting your tumor with beams of focused energy. So now you actually might just get radiation on some occasions if you have early cancer, kind of like surgery. But a lot of times you're going to get radiation in conjunction with something else. And a lot of times you'll get radiation after you have surgery, and people will say, well, why do I need radiation now? You just took my tumor out. Well, in following up from what we were just talking about with surgery, you know, cancer cells, obviously, if you were to take that tumor out in surgery and you left accidentally a little 1 or 2 cancer cells in there, a surgeon, when he's doing surgery, he's not going to be able to tell that there's a little cancer cell or 2 left behind. He can't. And these things do happen. There's no way you can prevent them. It does happen. And so we just can't tell. And we have no way of knowing. You can't do a scan afterwards and tell if there's 1 or 2 cells left behind. So the only thing we can really do is to give somebody radiation to that area afterwards to try to make sure that we kill anything that was left behind. And so if there's a tumor of a certain size, then we go ahead and assume that there's a likelihood that 1 or 2 cells might be left. And so we go ahead and do radiation after the surgery to go ahead and just cover all the bases, make sure that anything that might have been left is killed and gone. We don't want to leave anything up to chance. And then we might also add some chemo too to even really cover the bases. So that's just a tie-in to the surgery section I just did before that. But to just give you a little bit of an idea about radiation things that you might hear in the news and might be a little confusing, to give you, let me just give you a little historical lesson. When I first started doing cancer research in the early 2000s, radiation therapy was kind of like this. You know how you have a garden hose and you can put those nozzles on the end of your garden hose and you can adjust the setting and it adjusts the spray from being really wide spray to like a round spray or a mist or a jet or something like that. So back in the early 2000s, radiation was like if you have your garden hose and you put it on that shower setting and your water goes out to your garden kind of like this. That's kind of like how radiation was back then. If you had a tumor and you radiated that tumor, basically the radiation kind of went to the area around it. And people would kind of get these radiation burns around the area where the tumor was because it wasn't very precise. We could get it to that main area, but it wasn't super precise. It wasn't exactly where the tumor was. As time has passed, we've gotten better with it. We've been able to focus our beam on the tumor better. So these days, what we do is IMRT is what we call it, is a more focused type of radiation. At least IMRT is one of the more common kinds of radiation that we do now that is one of the more focused ones, and it looks more like this. It's more like if you imagine this is your nozzle, that spray nozzle that goes on your hose. You know that jet setting you can turn it to? If you turn that jet setting on there and it's that straight stream, and now if you imagine you've got that straight stream going straight to the tumor and it's more focused, that's more like what we've got and we do for people now these days. So you get less of that radiation burn and that's like over the outside of, you know, the area, because you're kind of hitting a big area. It's more contained to the area right where the tumor is. So this controls a lot of your side effects better, and really just helps with keeping a lot of these basically just side effects limited to the area that your tumor is, and not having them spread out and, you know, be in other areas where you don't want them. Now, the thing is, I do want to point out, because this confuses people, if you have heard of something called Gamma Knife or stereotactic radiosurgery, these things are radiation. They are not surgery, even though this has the word knife in it and this has the word surgery in it. Now, so why do they make it sound like it's surgery? This is because they're being cool. And here's what that's about. These are even more spiffy kinds of radiation, if you will. These are even more high-tech kinds of radiation. And what these are is, if you have a really funky shaped tumor, like that, these types of radiation are so super focused that they can almost trace the exact outline of your tumor and go right around it. So it's almost like they can just cut exactly around that tumor. And so it's kind of like they're using a knife to cut around it, and it's kind of like it's surgery, but it's not really. It's really is radiation. It's just very, very, very focused radiation. So don't be confused if somebody says they want to do gamma knife or radiosurgery, and you think, do I have to go to sleep for that? No, it's just radiation, but it's just very, very focused, very high tech radiation. So that is the general idea behind radiation. So now we'll move on to chemo. All right. Okay. So chemo, the big one. All right. There are two big categories of chemotherapy, and that's cytotoxic and targeted. Cytotoxic is old school chemotherapy. Targeted is what Will Smith would call the new hotness. This is the cool stuff. This is the stuff that people like me geek out on. This is the latest and greatest. This is what we're working on now. But before I even start getting into all that, let me start with an analogy that will help explain a little bit of what the difference is between the two and why we're pushing so hard to try to find more of these new targeted therapies. Okay, so this is going to be a little weird, so just turn on your imagination here. Imagine you're watching a sci-fi movie. Now, in this sci-fi movie, there are these alien terrorists that are good at blending in with the people around them wherever they go. And so it's really hard to tell them apart from just your average person. But they are always up to no good, and they're just murdering people left and right. So they have infiltrated a little island out in the ocean. Now, our military is going to come save the day, right? So they motor up in their boats, and they get to this island, and they're getting ready to go onto the island, and they're going to find all of these alien terrorists that have gotten onto this island, and they're going to get rid of all of them and make the island safe again. So they're getting ready to go onto the island, and one of the commandos says to their leader, "Sir, what do we look for?" And their leader says, "You need to go in there and kill anything that runs fast." Now, that's kind of odd, right? Well, the weird thing about it is that the only way you can tell the difference between these alien terrorists and your average kind of person, because they blend in so well, is that they never walk. They run everywhere. So the commandos say, "All right, we're going to do it." So they go in there and they kill all the fast runners and they come back to the boat. Mission accomplished. And so they killed almost all of the alien terrorists. So the island is safe. This is great, except for the part where they also killed a bunch of kindergartners on the playground that were playing tag, that were running around. They also killed a bunch of members of the high school track team that were practicing their 100-yard sprints. And then they also killed a mom that was chasing after her toddler that was about to run into the street. So you could say there was some collateral damage. So really, when you think about it, describing these alien terrorists as guys that run fast really probably wasn't the best way to describe them. You really needed a better description of these alien terrorists, right? You needed a better way to figure out who were the alien terrorists and who were the average native people, right? So that's kind of like this old school, as I'm calling it, cytotoxic chemotherapy. We still use this cytotoxic chemotherapy. Cytotoxic means cell killing. What it does, and it does it well, which is why we still use it, is it kills cells that divide rapidly. Why does it do that? Because, as we know, that's what cancer cells do. They divide rapidly. So, the thing about that is, though, we give you a drug that goes in and kills cells that divide rapidly, there's going to be some collateral damage, just like there was in my little example here. Just saying to go in and kill cells that divides rapidly, well, that's not the best description of cancer cells, because while, yes, cancer cells do divide rapidly, there are other cells in the body that also divide rapidly. So, give somebody some chemo that's going to go in and kill rapidly dividing cells. It's also going to go in and say, hey, it's going to look at the cells that are at the base of the hair follicle on your head, which also divide rapidly. Your hair itself is dead, but the cells at the base of the hair follicle, those divide rapidly. And so the chemo is going to kill those cells. So then you lose your hair. So then you also have these cells in your stomach that turn over rapidly because they are exposed to hydrochloric acid, and a lot of damage in your stomach all the time. So they're just constantly reproducing. So the chemotherapy comes in and kills them off. Then you get a lot of this nausea and a lot of these GI, gastrointestinal symptoms that go along with this old school chemotherapy. And then, if you saw one of my other videos, you know that your bone marrow is your blood cell making factory. And you may often hear people say that a lot of these old chemotherapies give you low blood counts. And that's also because in your bone marrow, you are rapidly making new blood cells all the time, just constantly making new blood cells. So the chemotherapy sees that and says, oh, look, there's a whole bunch of new blood cells being made here. These things are being made rapidly. Goes in there and kills those off, and then you have low blood counts. That's not the only reason why you have low blood counts, but that's a good chunk of it. So that really accounts for a lot of those symptoms that everybody associates with chemotherapy, with those older chemotherapies, right? So it's because these drugs weren't going in looking just for the cancer cells. They're just going in there and killing cells that divide rapidly. Like I said, they do their job well. And that's why we still use them. The upside to it is we can manage these side effects really well these days, much better than we used to be able to do. You're no longer going to throw up your guts and lose 50 pounds because you can't eat anything. We can manage the nausea side effects much better these days. I'm not going to say you're not going to get nauseous and you'll never throw up, but it's much better than it used to be. We can handle a lot. We have things to give you to be able to handle the drops in blood counts and things like that. We can just handle these side effects a lot better. So they're better able to be tolerated these days. But still, we'd much rather have something that is just going to go after the cancer cell itself, right? That's the ideal. And so any drug that we give you that's just going after the cancer cell itself is what we call a targeted agent or a targeted drug. Now, falling under this big category are a whole bunch of different types of drugs. And that includes the new immune therapies that everybody's talking about. It includes these things called monoclonal antibodies, small molecules, tyrosine kinase inhibitors, all kinds of things that are a lot of big long words, but it's basically basically all of the new drugs are in the targeted category. Now, what kind of things are we talking about when we say we're targeting things? Okay, so if you remember from my first video, cancer cells are they're all dividing rapidly because they don't know to stop, but they also have this thing where the immune system is not killing them when it should be, right? So we have two things that we're targeting. Sometimes we're trying to target something that's on that cancer cell itself. And then sometimes we're trying to target something in the immune system around that tumor cell to try to make that immune system or the immune cells around it do their job better. Now, originally we thought, if this is an immune problem, maybe we should just crank up the immune system. That was an early thought, but when we first started trying to mess with that, we found out quickly that's not a good idea. The immune system will kill you. Your immune system will kill you. Think about people that get stung by bees and die. They don't die because the bee stung them. They don't die because the bee's, toxin was poisonous. They died because their immune system overreacted, very literally. Their immune system was a drama queen and went way overboard and literally killed themselves. That's what happens in that situation. If you start tweaking your immune system and start trying to turn up the volume, so to speak, you can have very bad things happen. So we figured out pretty quickly, you don't want to do that. You don't want to turn up the whole body's immune system. We can't do that. So when we talk about the immune effects we want to have on the tumor cells, we're talking about just in the area of the tumor cells themselves. So we are looking at immune cells that are immediately around the tumor or things on the tumor that are sending out immune signals that are telling the immune system not to bother it. There are actually some things on some tumor cells that say, hey, don't bother me, I'm cool, things like that. And actually I will get into those much more in my next video that comes after this one, where I really talk more about some definitions of what some of those different targets are that we're looking at. So, like I said, this is the new hotness. This is the kind of stuff that people like me are really geeking out over. There are hundreds and hundreds and hundreds of targets being studied, hundreds of things we're going after. We're still trying to find the best thing that we can get our hands on, that we can go after. The ideal thing would be for us to have one thing that can go in there, look for the tumor cell, kill only the tumor cell, and be done with it. Unfortunately, thus far, what really seems to be happening is that we still need to give patients some cytotoxic chemo and some of the targeted therapy, or at least give them cytotoxic chemotherapy to start with, and then transition them to a point where they may get only the targeted therapy. So far, we haven't had a lot of success with just giving them the targeted therapy and having it work by itself without ever getting any of the cytotoxic chemotherapy. So you need thus far, we still need a combination of the two. So we're working on those, but those are the two major kinds of chemotherapy. So we hear about all these new immune things, and If you've heard there are a lot of commercials for PD-L1 inhibitors, things like that. These are drugs that are targeting aspects of the actual tumor cells or things that are immediately around the tumor cells that are allowing these drugs to go straight to the area where the tumor cells are. Now, I will say, just as a little aside here, I had a conversation with somebody the other day, and the guy said to me, you know, if I ever had cancer, I would do that immune therapy because it's natural. Let me just say this about that. Well, any drug that you put in your body is a drug. An immune therapy is going to be a drug. A targeted therapy is going to be a drug. Whether you put it in your mouth or whether you get through an IV is no different. They are all drugs. Whether it is an immune therapy or not, all of these things are being given to you to treat your cancer. And guess what? Some of our nastiest chemotherapies come from plants. Don't delude yourself into thinking that natural is harmless. Mother Nature is vicious. We get many, many, many of our chemotherapies from Mother Nature. Immune therapy is these drugs that are immune therapies, they're drugs. They are things that the FDA has to approve. Yes, we are trying to target your immune cells to make them do things. That doesn't mean we're not giving you a drug. That means that drug we're giving you is working in a different way. It has a different mechanism of action, as we would call it. That does not mean it doesn't have side effects. Now, thus far, the side effects for targeted agents are usually less than these cytotoxics. Like I said, that's what we're going for, but it doesn't mean they don't have any. It doesn't mean that some people won't have severe side effects. So don't let yourself be fooled by those kinds of arguments or that kind of thinking. Everything you put in your body, including food, technically, here's a fun point for you. Fun thing to say at a party: food is a drug. Everything you put into your body is a drug. And if you look up the chemicals that are in an apple, it'll surprise you. An apple is made of a bunch of chemicals that are words that are that long. Everything that we put into our body is made of chemicals. Shocker, I know. So that whole natural thing is often an illusion that we create for ourselves. It's not so simple. Anyway, that's just a little aside, a couple little things to make you think. But regardless, this is the summary of chemotherapy, and watch my next video to really get into more detail about these targeted agents. And I'll talk a little bit about the PD-L1 inhibitors. I think I touch on PARP inhibitors there, and a little bit more about the immune stuff that's going on right now. That's about it for chemotherapies and for cancer treatment as a whole. If you have any more topics that you're really interested in hearing about, make sure you leave a comment about those and I'll see what I can maybe do in the future. But for now, make sure you like and subscribe if you think this is useful. See you soon. Thanks. Bye.